This video is part 4 in our 5-part series on why mid-back pain between the shoulder blades usually isn't a rhomboid problem. In the video, I cover the following: a breakdown of the lower cervical erector muscle group in the mid-back, palpation and treatment demonstrations of scar tissue in the lower cervical erector muscle group, and treatment tips and tactics to get long-lasting results. For those of you who don't know me, my name is Dr. Matt Maggio, and I am a non-surgical expert in chronic pain treatment, specifically for headaches, neck, upper back, and shoulder issues. My focus is on finding and fixing nerves that become stuck to muscles with a glue-like substance called adhesion, also known as scar tissue, and then reducing inflammation from chronic pain naturally without the use of medications or injections. This leads to a big increase in flexibility, functioning, and long-lasting pain relief. I'm also the creator of the Peak Method, where we teach massage therapists a new treatment system that eliminates the frustrations of not getting consistent results and produces long-lasting pain relief for their clients, all while working 50% less. All right, this is part 4 in our 5-part series. If you have not watched any of the other ones and you're watching this on YouTube, I will link it up top. Anywhere else you're watching this, it'll be down in the description box below. But let's get into it. Usually why pain in here isn't a rhomboid problem. Today I'm going to be talking about scar tissue formation in the lower cervical erector muscles. So the cervical erector muscles are really important, and there's a lot of them as we go in there. And sometimes when we're thinking about anatomy and we're doing it, we want to be very precise and very focused about which muscle it is, where it's going, its origins, its insertions, everything like that. But when I'm talking about the cervical thoracic area, I'm not really trying to differentiate between if it's like semispinal cervices, splenius cervices, any of these listed here. I'm really just checking throughout the entire region. Basically, we're looking anywhere, I'd say, from like C7 to about T4 as we're going in there. So I'm not really trying to specifically isolate one single muscle. I'm really just seeing where it's gunked up with that adhesion and what goes on, because they do get stuck together, especially in like mid back pain and chronic neck pain. So why does this area develop so much adhesion? I talk about this a lot, but with bad postures, with sitting too much, not moving enough, maybe looking at phones all day long, what happens is the muscles get constantly stretched and contracted. They don't get enough blood flow. They don't get enough oxygen. So the body actually starts to lay down adhesion or scar tissue to the area to kind of help buffer the area and give it like a short-term help in its force production. But then it gets bigger and bigger. Then it causes a lot of problems. When there is adhesion in there, usually what I see is it's like tight, limited range of motion, maybe some minor pain with treatment, maybe even like some tenderness to the touch and things like that as well. Because when the muscle develops a lot of adhesion, the first thing you start to see is decreased flexibility, and then you also see some weakness in there as well. And it's very, very common to have adhesion build up, especially if someone's coming into your office, they're making an appointment because they're in pain, they're not functioning good. The chances of you finding adhesion is really high. What I want to include first in the video training this week is actually a detailed palpation of this area and really getting in there and being able to figure out exactly where the biggest restriction is, where the biggest part of the adhesion is, so you know exactly where to go. I always say if you don't know where it is, you can't find it in the first place. So what I'm going to link up first in the video is a detailed palpation using landmarks to really help you isolate where this problem is. So let's link that video up right now. The next thing that can limit this test in here is just overall scar tissue in the cervical thoracic spine erector group. So what I like to do is I start very similar to how we did in the low back. I start right up against the spinous and I just kind of work my way down till about the mid T-spine. And what I'm doing, and then I go over about a thumb width and I go up again, and then I go out lateral one more time. And then I'm really just kind of feeling the tissue, trying to figure out which area has the most tension, which is compressing the least. That's how I know that's the area that I want to treat through there. So first thing is to clear up all that accessory nerve, find that palpation. Next one is to go in there, find the rest of that scar tissue down in the cervical thoracic spine and clean that up. As always, get your depth and your tension on it appropriate
break down that scar tissue, but account for that 45-degree angle. So if you go too much in there, it's going to be compressive as you go.
So just again, the importance of like slowing down, palpating, finding the area. You know, a lot of providers and manual therapists, massage therapists, and I did this myself over the years, is we just want to jump right into the treatment. And a lot of times we just rely where the client tells us where it hurts instead of like trusting our feel and our touch. If we slow down and do the palpation right, we're going to find it. What I want to include next is actually a detailed treatment video, kind of going through how we do it, how we get proper depth, proper tension, body mechanics, and everything like that. This is actually taken from our advanced CEU training course. So I'm going to link that video up right now.
So now we're going to get in here and we're going to actually treat the scar tissue in these erector groups. As you looked at that palpation and watched the palpation video, kind of goes in 3 layers. You know, as a thumb, this is where the spinous is. You have the 1 thumb length here, then you have 1 here and 1 here. Now, the closer it is to the spine, we're just going to have straight flexion down for the treatment. As we get further out, we're not going to just have flexion, we're also going to have lateral flexion away. That's going to help these deeper erectors open up. The problem for the thoracic spine is it's very curved in through here. It's the opposite of the cervical and the lumbar spine. And what happens is people end up being too compressive in here, and they go in there and they get way too much depth and not enough tension. And when you do that, you actually trap the tissue. And when you trap the tissue, it's actually not a good treatment. It's not breaking it down. In order to break that scar tissue down, we need the proper depth and the proper tension. That's why lining this up is really important. So for this one, you're going to need the client to help you with this motion. The first thing that I like to do is I take their arm and have them bring that across just like that. What that does is it kind of pulls the rhomboid out of the way, some of that accessory nerve, and allows that to open up. So we've identified with palpation where our problem is. Now, you're going to take the client, you're going to say, you're going to go nice and slow, and I want you to slowly drop your head down like that. And a lot of times they're going to want to drop their head really fast, or they're going to go too slow. You want them to have just the right amount of movement. Now, we've identified the scar tissue and where the problem is. So let's say the scar tissue is right here, and we've identified that with our palpation. We want to set up just a little bit above that. So here's where my thumb is, and this is the key where the elbow comes high. Now, all of our contact is right through here. The next thing we're going to do is we're going to line this arm up just like that, and it's going to block and cover my thumb. And as we practice in the warm-up drill each morning, is the first part of that is going to be your depth, and your depth is going to come from a slight lean in like that. We practice this each morning. It's important. Now our tension is actually going to come from a drop with the body and a drop with the elbow. And you see how I'm staying nice and lined up through here. So the key here is that's there, here, and our depth comes just from that body lean, and we keep our depth with a push from this opposite arm. That's where you're going to get your depth. A lot of times if you push too hard, the client will kind of move too far forward. You want to be very precise and focused, because if you don't accommodate for the curve of this spine, it's not going to work. So we found the spot. Essentially, we're going to line up just like that, and we're going to lean in. I'll get a little more depth with this other hand, and it's all pushing through my thumb. I'm going to drop the elbow, drop the body, and I'm going to go in until I feel that peak tension. And then the client is going to go through that motion and go straight down, and I'm feeling that go right over my thumb. Now, the majority of the tension is coming right from this thumb. I actually lift the fingers off on the other side and come here. A lot of people tend to grab, and when you get grabby, you don't get good tension. So I'm going to do one without the thumb backed up so you can see it. So here's the motion, and then you would get in there where you sink in, and then the tension from the body drop. And go ahead, and you see that start to tension.
All right, so you can see in the treatment video, it's very deliberate, it's very slow, it's very focused, using mechanics, levers, proper body position, everything like that. When people are usually treating this area, some of the main errors that I see in the treatment is first not accounting for the vectors of the curve of the thoracic spine, because the thoracic spine is a little bit different because you have the ribs, so it becomes more what's called kyphotic instead of lordotic, like the cervical and lumbar spine. So a lot of times what I find is people don't account for that with their elbow positioning and how they line up, and they end up just trapping the tissue. And when you just trap the tissue, you don't get the proper depth and proper slide to increase the tension. It only temporarily feels better, but you don't actually make that change in the muscle and remove the adhesion. Next is starting with the muscle first, and not addressing the nerve entrapments and ligaments first. I covered those in the other videos, but basically, if you don't remove the nerve entrapment first, everything's going to kind of tighten up and go back to where it is and engage in a protective tension. So you want to get rid of the accessory nerve entrapments first, the dorsal scapular nerve entrapments first, and then the ligaments, then do the tissue last, because that's what's going to have that long lasting pain relief and function in the tissue. Next is just having the client go through going too fast through the active range of motion. So we really want them to be slow and deliberate. I spend a lot of time like coaching the client how they move and how they want to go, because this area is going to be pretty tender. It's going to be sore to the touch, and the client's going to want to get through it fast. But we want to have optimal time under tension to break down as much adhesion as possible in every single pass. Lastly, is just doing too much treatment dosage. I always say when you find a palpable adhesion in an area, you maybe want to do no more than about 3 to 5 passes on that area. And a lot of times when people are having issues in there, chronic neck pain, mid back pain, there's also a component of like degeneration in the spine, especially in the discs and things like that. And they can only do so many ranges of motion dropping their head down. So the more you do, you're actually risking the potential of having a flare up in that area. So I always say do less than more treatment, because you can always recover from that. So don't just hammer on that area, and definitely don't use your elbow. Use your hands, feel that tissue slide. The elbow is just way too compressive and it's just going to hurt like hell. You're going to think you're doing something, but you're not actually fixing anything. So all I got in the video. I appreciate you watching. If you got any insights you saw from it, drop them in the comments section below. I try my best to engage and talk with anyone that sends in stuff. I want everyone to learn and share my knowledge as well, and I can learn from all of you too. Next is just share this with any other providers, that it might help, that are maybe looking to do good work. They want to help people in chronic pain get longer lasting results, better quality treatment, and everything like that. And lastly, if you're interested in what we do and you're frustrated with not getting consistent results, you feel like you never really have a plan of what's going on and you're just working way too hard, go download our free training modules. In that, we really teach you the idea of like thinking critically, problem solving, doing more precise and focused treatment instead of just doing like a shotgun approach, and getting a lot better results. And you get all that information in the free training. And we teach you a very common problem, which is chronic neck pain, and show you how I go about addressing it, finding it, fixing it, and getting results driven treatment so you get amazing results for your clients. I appreciate you watching, and we'll catch you on the next one. Bye.